Good afternoon, everyone. It's my great pleasure to introduce our grand round speaker, Lisa Walke. She is the chief of the Division of Geriatric Medicine for the Perelman School of Medicine at University of Pennsylvania. She is leading the University of Pennsylvania into an age-friendly health system through innovation in clinical research and education programs. So prior to her position at the UPenn, she was at Yale University, where she directed and developed several educational programs for medical students as well as for geriatric fellows. She is an expert and clinical leader who has received many accolades for her excellence in. She is a member of the American Geriatric Society Clinical Practice and Model of Care Committee, Secretary and Treasurer of the Association of Directors of Geriatric Academic Programs, and a member of the American Board of Internal Medicine Geriatric Medicine Board. Her research interests lie with improving health outcomes for older adults through innovative care delivery models. I'm looking forward to hearing her vision for geriatric medicine beyond 2020. Please join me in welcoming Dr. Walke.
Thank you. Thank you so much, Michi, for that introduction. I also want to thank Louise for the invitation. We were hoping originally it would be in person back in April and in person this month, but I think this has worked out well. So thank you so much for the invitation. And I also want to thank Elaine Chow for helping with all the technical issues right up even to the last minute of helping to get through. So thank you all so much. So I think it'd probably be a little bit of an understatement to say that this has been a unique year. And I wanted to take some time to kind of journey through the year and reflect on what's happened and how geriatric medicine as a field has kind of pivoted and where we stand now, in my opinion, in terms of moving forward throughout the remainder of this year and also certainly in the future. So I am going to use what's happened within my division because I know it best as an example, but not that we're anywhere unique. I'm hoping that the examples that I give will help you think of how you pivoted at UCSF and how you may know that others pivoted in geriatrics to deal with the issues that we were confronted with this year, and how I think that makes us stronger as a specialty and where we can go from here. So more specifically, I'm going to detail how the scope of care provided by geriatricians, and I'm using care in kind of quotation marks, not just clinical care, but how we interact with older adults, how that has changed and expanded because of COVID-19, describe efforts to address the disparities that we know have been highlighted by COVID-19, as well as the ongoing racial justice movement, and how that pointed out some disparities in health for older adults. Particularly older minorities. And then again, as I mentioned, focusing on ways that geriatricians can remain what I'm calling fully engaged, fully at the table, part of the conversation, leading the conversation beyond 2020. So I want you to think back with me to 2019, the BC, which I called before COVID. And back then, the end of last year, there is so much vision and hope for the year 2020, right? The year of perfect vision, of being able to see things clearly. And these are some of the slogans and logos that I'm showing that different organizations were using, that we would be able to see our results, what our mission, have a clear focus for a goal. And so there was a lot of excitement as to what this year would hold. I particularly thought that these slogans and this approach was quite clever. I've been wearing glasses since I was in the 4th grade, as many of you have been. And so the thought of what would it be like to have 2020 vision, you know, to have perfect vision, to be able to see where we needed to go and then be able to do it, I thought was quite clever, and tried to pivot and say, what would be 2020 vision for me and at my institution and for my program. And so for us at Penn, 2020 was really the planning of looking ahead to 2021. That's what it was going to be, because as you can see here on the left, this is the new pavilion that is now built but being completed on the inside of the hospital of the University of Pennsylvania, the flagship hospital in our healthcare system. So this little part right here is where HUP is currently. So this will be called Hub West. This is going to be called Hub East. And so most of us at the end of 2019 were trying to make a pitch to say that we should either be in Hub East or why we should be there, and planning for 2020 of what space we can get. Well, I got reached out to by Ryan Grayson, that I know many of you know, who's in hospital medicine, had been at UCSF and now is at Penn. And he reached out to me and said, you know, everyone's vying for Hub East. Well, why don't we get some space in Hub West, our current hub? Once people move over, there'll be additional space. And maybe we can get a pitch for having an ACE unit in Hub West, one that would be primarily managed by the section of hospital medicine with geriatricians as consultants. And then we can say that would be part of our age-friendly health services on this campus, which he knew I was trying to promote. And this is really where I've been, of trying to get Penn Medicine as age-friendly. So it totally made sense for us to collaborate and work together. How can we at least get this first building block on the path to having the whole health system be more age-friendly? And it also built upon a work that Ryan and I had done recently at that point in time, where we had done an editorial describing why every hospital should or must. I wanted to go the should route, Ryan wanted to do must, so we compromised and put both in the title, have an ACE unit by 2040, and really giving the data and the literature that we know to support the care that happens on ACE unit, how it's better outcomes for older adults, shorter length of stay, less discharge to nursing facility, less likely of adverse outcomes at 30 days. So we made our pitch to the senior management at the Hospital University of Pennsylvania. Ryan did his part looking at hospitals in the aging century. And so from a hospital medicine point of view, we're just kind of smack dab in between these two circles, where 10 years ago, it was predominantly adults who are under the age of 65 in the hospital, but we're expecting that within another 10 years, it'll be the flip and it'll be older adults. So from a hospital medicine point of view, it made sense for us to have an ACE unit and to have one as part of the hospital overall once the new pavilion opened. I added on from a geriatrician's point of view that we know there are older adults are increasing, and no surprise to any of us in terms of knowing that. Pennsylvania is an older state, not quite as a high proportion as California, but we are up there kind of right behind. We're about 17.6% of our population are older adults. So I made the pitch that we already have a high number of older adults that's going to increase. And if we know we have a lot of older adults, we know we're going to have a lot of older hospitalized adults as well. And then I ended my portion of the presentation in a way that I typically like to end when I'm discussing or talking to non-geriatric trained people about why do we want to optimize geriatric care, why do we even want to do this. And this is a quote from Chris Carpenter that I like to use very often, typically at the end. And he said, geriatric adults represent a canary in the coal mine for our healthcare system. Because if we as a profession can effectively care for this challenging population, we will undoubtedly provide exceptional management for the non-elderly. And typically I'd say geriatric care is just good care. It's the care that we want for ourselves. It's the care we want for our loved ones. Well, it was kind of interesting that back then, at the time we were making this appeal, not quite a year ago at this point in time, that didn't know how accurate the statement was going to be, that if we can effectively care for this challenging population, that we're going to provide exceptional care for everyone overall. I think we've seen that that's truly the case over the last couple of months. So shortly after our pitch, and senior management agreed with us, they said that we should have an ACE unit in the pavilion, the Hub West. We were having plans on spacing and what environmental changes needed to be done, what additional staffing would we need, and we had a timeline set out that we were going to continue. And then, you know, everything changed a couple months after that. And like things that have happened before, obviously it wasn't a change just with us. It was a worldwide change. So things were different, but not completely different. We had to pivot and change what we were doing with the clinical care that we were providing. And so we have a geriatric surgery co-management program. We collaborate with trauma and 3 different types of trauma: ortho trauma, but as well as neurosurgery and general trauma. And so trauma clearly isn't scheduled. That really didn't change that much for us in terms of our volume and the patients that we were seeing. However, our colleagues in hospital medicine have a co-management program with general orthopedics, so more of the elective procedures that they're doing, and they were managing their patients with them after they came into the hospital. Well, the hospitalists in our healthcare system got pulled largely to provide COVID care and to also assist in the ICUs. So they reached out to Mark Simone, who's the geriatrician I'm showing in this article, and myself to say, would we pick up that aspect of their work? Would we take over doing preoperative assessments and perioperative co-management for younger adults and for adults who didn't have trauma? So we actually wound up pivoting and expanding what we were doing during this point in time to be able to be supportive to our colleagues as they were trying to manage new responsibilities that they have been asked to do. We also pivoted with our house calls program. And so for a period of time, we stopped doing house calls when we were really at the very beginning and the peak and not being sure who had what, and tried to switch to a virtual format of doing telemedicine for our patients. I'll come back to telemedicine a little bit more, but it became kind of clear to us pretty early on that it wasn't going to be sufficient for our house calls patients, that some of them really needed to have in-person visits and in-person care. So we pivoted then in terms of what we were doing, and like I'm sure all of you gowned up, used our full PPE. Obviously didn't have a separate pool for our house calls program, so we were using what we have within our division overall and giving each member their own bag and their own setup to do house calls, which has changed the way we interact with our patients. Obviously, we're usually not all gowned up. We don't know who in the house may have COVID or other conditions, even though we ask for only the main caregiver to be in the room. And so we've had to pivot and change in terms of how we're doing house calls, and this is what it looks like since COVID. But the one of the biggest changes, as I mentioned, was how we were doing ambulatory care. And so Penn had a contract with Blue Jeans. I had never heard of Blue Jeans before. I'm sure most of you had not. And so, but that was the platform that they wanted us to use for our virtual visits. So we switched to having Blue Jeans visits, and the preferred was video. Well, most of the patients had a Blue Jeans app. They had to download it. And we quickly noticed that there were some issues. You could enter a room while you were still talking to another patient. And so they came up with this switchboard function. And switchboard allowed there to be a kind of virtual waiting room, so to speak, so you can have a patient waiting instead of entering your other visit. But it still meant that our patients had to use technology in a way that some of them hadn't used before. So it became clear we had kind of 3 categories of patients that we were interacting with. We had people who had the technology but didn't have experience using it or weren't comfortable using it. And the people that normally would help them, i.e. their adult children or grandchildren, weren't around because we were recommending that people not visit their older adults, right, in terms of trying to keep them safe. We had a second group that was not insignificant who didn't have the technology. They didn't have a smartphone, they don't have a tablet or a laptop, and so virtual visits was just not a possibility for them. The best they could do was telephone visits. And so that was a real eye-opener for us in my division in terms of the disparities that we had right there with those 2 groups. And then the third group were individuals who had the technology and knew how to use it and didn't want to use it. That was earlier on. We were able to educate and work with them. we heard excuses like, I don't want to get dressed, I don't want to do my hair. You know, they wanted it to be more of a kind of social visit. And as we got people to understand this was therapeutic, not just a hello, hi call, that we really needed to see them, that it was part of our assessment and evaluation, that third group we were able to turn around. But the first two groups really let us know that there were some disparities that we had to address. And then we got emails. So I don't know if you're like me, but got tons and tons of emails. And so we got emails from senior leadership and from others. And initially the emails were updates, what was changing, what was happening, what was new, what was the recommendations. We changed quite a bit in terms of PPE and what we needed to wear. And I was just inundated with emails. I think I probably got more than others. But as we were going longer through the process, it became clear that we needed some boost. We needed some pick-me-ups. And so the CEO of the health system asked each hospital CEO to highlight one program or one part of the team in their hospital that they thought was doing a stellar job during COVID and should be recognized. And I want to share with you this video that the CEO of Penn Presbyterian talked about our unit. And hopefully it'll work.
Hello, Penn Medicine family. Today, I'm joined by Michelle Walke, CEO of Penn Presbyterian Medical Center, to share with you a moving story of our healthcare heroes.
This pandemic has brought so many people together. Many, many people have had to step up. But there's one unit that really stands out, and that is the acute care for the elderly unit. Patients in our ACE unit with no visitors in the hospital are isolated. The team on the ACE unit made it so clear through their actions that not one patient was ever truly alone. And so team members began doing coloring book projects, playing games with them, bringing in puzzles, talking about their families with them, and they became their conduit to the outside world. Through technology, the staff on the ACE unit was able to reunite ACE patients with family members. Once that patient saw the face of their loved ones, they just lit up. That has had such a positive impact. I am tremendously proud of the ACE team. I think that they are doing angels' work. What this pandemic has taught me is that the team here at Presbyterian has trained for this their entire life. Together, we are Penn Medicine.
So of course, there's a little bit of a rah-rah and trying to generate some good spirit. But for us, it was really important because our ACE team had been working really hard, and it was nice to have that recognition of what we were doing and to keep people buoyed up in terms of what we needed to continue to do, because clearly we weren't out of the woods. And just for the record, we didn't have COVID patients on our floor. So, well, technically, when they became clear that they had COVID, they were transferred off. So we were dealing with non-COVID patients on our unit, but still trying to manage, particularly with having no visitors. And then after we were just kind of getting somewhat of a feel and understanding of how things were going to go, we had the very distinct honor of being the medical directors for the first nursing home in Pennsylvania to have COVID-19. And this is Josh Wee, who you saw in the video as well. He's the medical director at Renaissance. And when COVID hit at Renaissance, we didn't have any colleagues or individuals here to reach out to because it hadn't reached us yet. And so he spent time calling California and Washington State and the AMDA colleagues and others to hear what was it like to have COVID patients? How did you know that they needed a higher level of care? What needed to be done? He was literally going in at like 2 o'clock in the morning trying to assess people to see if they needed to go in, because he didn't want to just flood the hospital and have everyone go in. And he knew that his facility could manage a certain level of acuity, but it was definitely a challenging time. And shortly after COVID hit Renaissance, it was we were in the newspaper with that regard, and it described his experience and talked about how hard he was working and taking care of our loved ones. And there's a really positive tilt to this story and reinforcement. Josh then got reached out to a lot after the Philadelphia Inquirer, so he was on television or NBC station talking about coronavirus. He was on the radio with our branch of NPR talking about COVID, and was able to start realizing we had a platform that we didn't quite have before, and started reaching out. And that was true not only for Josh, it wound up extending to many of us, and I'm sure you guys had the same experience. I got a call from one of our state senators that he was going to do a telephone town hall, and he wanted me to be part of that conversation to talk about coronavirus and the impact on older adults. So it seemed like kind of almost overnight, we went from a field and a specialty that people weren't really quite sure what geriatrics is. You know, some people thought we were dietitians for older people. You know, what does geriatrics do? How is it different? To people recognizing and understanding that we were experts in care of older adults, and everyone seemed to be reaching out all of a sudden as they were trying to educate and inform their constituents. They were reaching out to us in many different ways. And so APHA, the American Public Health Association, collaborated with the National Academy of Medicine. They had a whole series on COVID-19 conversations. I think they had about 18 or 19 total. This was the second one. And as you'll see, there are a couple of geriatricians. Sharon Inouye was the moderator for the session, and Jason Karlowicz, who's one of the faculty at Penn, was one of the panelists. And they were talking about the science of social distancing, and this was the second part of that conversation. But again, reaching out to us to have us give our expertise and understanding of what we needed to know, what we needed, the public needs to be aware of to know. So a lot of public education. And Jason, whose interest, his research focus is on Alzheimer's disease, was also reached out to do a live session on the Being Patient Alzheimer's Facebook. So again, forward-facing to patients and their loved ones, their caregivers, on how do you manage hospital delirium and dementia when we were in the era of COVID-19, and knowing that there weren't visitors and people not being able to be in therapeutics. So just really doing a lot of people reaching out to us so that we could help inform and educate the public. But then we realized that we had an opportunity, and when I say realized, I don't know that we consciously realized it, but somewhere in the process, since people are listening, people now know who we are and what we do and what we have expertise in, we kind of pivoted a little bit, and we decided to reach out and push out information. And so did a lot more op-eds than we normally would do. And the audience for this one was older adults and caregivers. And it was written by Mariana Gonzalez, who is one of our fellows at the time. She has a background also, and she has an MPH as well as her MD. And then Rachel Miller, who is our director of education. Early on in the pandemic, they wrote a kind of a how-to guide for older adults and their caregivers. How do you weather the pandemic? And that was well received and got a lot of attention in our area. Josh, it didn't take too long, unfortunately, to go from the, wow, what a great job they're doing, and this is challenging, and what's happening, and how wonderful care we're giving, the really positive article, to the kind of backlash that we were getting in the public of nursing homes aren't giving good care, and they aren't taking care of people, and it's their fault that it's spreading. And so he went from being interviewed to writing this op-ed with an appeal to the general public, saying that, you know, the nursing homes need help, not blame. Could you volunteer to give meals like we're being given to hospital workers? You know, healthcare workers in the hospital would be being called heroes, and were being applauded for what they were doing, and people in the nursing home who are doing equally difficult, if not more difficult work with fewer resources, were getting blamed. And so he wrote this op-ed to give his side of the story. And then Jason capitalized on reaching out to hospital administration to say that hospitalized older adults, they need their caregivers. It's not just people visiting, because there are so many no visitation, no visitor policies, and uses research in terms of Alzheimer's and knowing what we know about the therapeutic benefits of caregivers, and saying that hospitals needed to allow some caregivers. And we targeted our own healthcare system because, as you heard in the video, there was a no visitation policy. So the only individuals who were allowed to have visitors were people who were actively dying, which of course was hard to calculate. It typically meant more ICU patients who were allowed to have a visitor. And again, the timing, it didn't always work out that the family or whomever was able to get in time. So there were people who sadly weren't able to have a loved one with them as they were dying. But we really want to advocate, and Jason used this platform to advocate to say that people with dementia, that their caregivers are therapeutic. They're not just visiting. And part of the reason why we were having a little bit more of a spike in delirium and agitation on the ACE unit and others with older adults is because individuals with dementia didn't have that familiarity with them. And so after several meetings with senior leadership and continuing to make our case, we were able to get the visitation policy changed at Penn Presbyterian, that now one visitor is allowed during restricted visiting hours, but we can get exceptions for persons with dementia for their caregiver to come with them. It's only one caregiver, it can't be multiples, and they have to stay there the whole time. They can't be kind of in and out if they're going to stay overnight, but at least it's an improvement. We haven't yet been able to get HUP to change the policy, so it's still a no visitation policy at HUP, so we're working still with them. But this pandemic also led to us doing some new partnerships. So I had mentioned earlier that for ambulatory care in particular, we were doing virtual care, and it became obvious not too far after we started doing so, the issues I mentioned, the disparities of not everyone having access or being comfortable using it. So Geriatrics Online is a not-for-profit group in our area that reached out to me, and they said, we want to help. And before COVID, their focus was to get older adults comfortable with using email, the web. They would do classes and courses for either senior housing complexes or for individuals with the older adult teaching. So kind of peer-to-peer teaching to make people more comfortable with using it. And so once they heard and recognized some of them themselves had had visits that were virtual, they were concerned that other people wouldn't be able to access. And so they reached out to us. And when we mentioned that some of the issue was individuals not having the technology, they went about purchasing some tablets to be able to distribute to some of our patients, and are still working to try to get a collaboration with Blue Jeans and such to be able to have either wider access or more technology that we can spread. So this has been a new partnership that's been really beneficial to our patient population. And then our medical students also got in the midst of it, and being innovative and pivoting and coming up with ideas, and developed the One Extra Bag initiative. And so initially what they were doing is buying one extra bag of groceries for residents when they went to the store. But then I'm showing Eden, who is a member of Grandmas, which is the Geriatrics, Aging, and Neurodegenerative Diseases in Medicine and Society, basically our interprofessional aging health professionals group. And she decided, could we expand upon it and deliver one extra bag of groceries to our house calls patients? So she reached out to Allison Mitchner, and who's the faculty advisor for Grandmas, and to Rachel, who's also one of the advisors, and said, is there a way that we could do this to help the house calls patients? So one student was paired up with one older adult, and every week as that student was going, they would call the older adult over the telephone. So they didn't have to have technology beyond what we knew that they had to be able to get help and food delivered. And the students who had some time because they were not in classes felt like they were contributing, and the older adults loved it. And it gave some socialization, even if it was from a distance, that was sorely, sorely needed. So I know I've been focusing a lot on clinical care, but as I just started to allude to, obviously there were impacts on COVID on education and our research missions as well. For the medical students, and in terms of education, they were all pulled from their in-person rotations. And that's part of the reason why they had time to be innovative and come up with things like the one extra bag. So they were looking for ways to be helpful and relevant, and if they couldn't be on site or in person for their education. Our residents really took the main brunt of it. They were pulled from ambulatory rotations. Some people's vacations had to be postponed or rescheduled, and they really were the primary COVID teams taking care of the inpatients. They also were rotating in the ICU as well and helping take care of the critical ill patients who were predominantly COVID positive at that time. And then probably, as it was true for you as well, our fellows, we went to I think it's called a stage 3. I can't remember what the title was, or level 3, that fellows could be pulled from their fellowship to function as attendings in your primary specialty. So our fellows could either be pulled to be family medicine or internal medicine attendings if needed. I made a pretty strong pitch pretty early on that wasn't going to work for our fellows to be pulled, because we also had to take care of patients in the nursing home and no one was helping us there, and we needed to be on site there as well. So we had a couple of fellows pulled to help out in the COVID tents where testing was done, but never anyone that had to go for prolonged periods of time to do an inpatient team. But that was always a possibility in the background. And I think probably hardest hit out of all of our missions was our research mission. So on March 13th, the decision was made that all on-site research had to be halted. It had to go to 100% remote work. Everyone doing investigation had to pull off campus. And so for our health services researchers, while it was a hit, it wasn't as bad because most of them could still do their work fully remotely in terms of their investigation. But for individuals who were doing clinical investigation, clinical trials, that meant they were put on hold for an indefinite amount of time. And although we don't have basic scientists doing animal research in our division, other divisions did, and that research also had to be put on hold. So animals had to be sacrificed, and total projects had to come to a halt with loss of a lot of time, productivity, money, everything you could think about. So it was very uncertain and a really big hit for our investigators. And just as we were getting kind of settled into what that was going to be and what's our new norm, and had been pulled out for a while and working remotely, then everything changed again with the murder of George Floyd, and really just rocked our community and our society, and made things very different from the way they were before. In the first few days after, there was just a lot of reflection and discussion, and one of the things that I thought really spoke to me and just I thought was very healing was this poem. So I am showing you one of my colleagues who's actually the chair of medicine at Penn Presbyterian. One of his sons has autism, and I'm showing him in the picture. And until about 3 years ago, because he doesn't speak or doesn't speak much, they thought that perhaps he was intellectually delayed, but they realized working with the therapist that he can communicate very well with the communication board, as I'm showing in the picture that he's doing. And once they realized that, he has just been talking and communicating, and he has a blog that he calls The Autistic Mind Finally Speaks. And this was a poem that he wrote after George Floyd's murder, and his father shared it with all of us, and I want to share it with you because I think it was just so on point for how everyone was feeling. So it's called Black and White and Love and Kindness, in memory of George Floyd. Color and the outside of us are a way to identify our heritage and nationality. It does not identify our character or intent. All of us are human and identical on the inside. If you cut us, we bleed. If you punch us, we bruise. If you step on our neck and hold us down, we die a terrible death. This is not the way to treat our brothers and sisters. Animals aren't even treated that way. George Floyd deserved better. The way he died on the street and suffocated is a nightmare in true life, and it needs to stop. The people need to be kind first, then suspicious later for good reason, not because of appearance. Autistics and Black people are misjudged all the time. I have lived it, so I understand how it feels. It could be me one day being held down for a misunderstanding of my autistic outsides. All we need to do is to begin by wanting better than we have now. A world of love and kindness is not that far away. All we need to do is choose love first, and the rest will fall into place. Be the change. And so I think just realizing how this impact was on Philadelphia and in terms of the location makes a difference. So Philadelphia is a diverse city. I'm not a native Philadelphian. I'm native from New York, from Queens, New York, and I've only been in Philadelphia for a little over 2 years. But the resident breakdown is, as I mentioned, quite diverse. It's about 44% Black, 36% white, about 14% Latino, and about 7% Asian. But what's interesting about Philadelphia, but apparently is not uncommon for large cities, is that it's quite segregated. And so Nate Silver, who's the founder of 538, said that Philadelphia is probably the 4th most segregated city out of the 100 biggest cities in the United States. So meaning while there are all these groups of people, you live in neighborhoods that if you just look at the neighborhood, it's predominantly everyone that looks like you. So it's little groupings, but not all integrated. And so in that setting, having something like George Floyd's murder, you can imagine how it was. And that combined with COVID, which we've seen quite a bit of literature that there's a interaction or a correlation between age and race. And so this is a recent article that was in New York Times, of all places. They've been really following COVID, but they look at the coronavirus cases by 100,000 people, and you can see it's highest in Latinos and Blacks. And then when you look at it by age, for the 80 plus or the 79 plus, it's most prevalent in Black and brown populations. So you add the disparities that we recognized ourselves because of COVID, and then you add on the kind of emotions and feelings from George Floyd's death, and it just changed the environment. And so there was really a call to action within our health system and within our university to shatter the silence, meaning that we needed to speak about this, speak about how we felt as healthcare providers, as investigators, as educators, because our job was going to be impacted and how we delivered it if we didn't. And so recognizing that silence is inhumane in the face of suffering, Dr. Martin Luther King Jr. had said that in the end, we will remember not the words of our enemies, but the silence of our friends. And recognizing that silence will prevent the real change that many people were demanding at this point. And we know from prior social movement research that when a majority group stays silent, it's as if they're licensing the oppression of the marginalized groups. So in my division, we decided we didn't want to be part of that, and we wanted to shatter that silence. And Penn Medicine overall held a White Coat for Black Lives event on the football stadium. That's what I'm showing on the left at Franklin Field. On the right, these are some of the members of my division who participated in that event, and we thought it was important for our patients and given our specialty. A few weeks later, on Juneteenth, the health system and the university decided to have it as a holiday. And they said that we hope you will treat this day as an opportunity to learn from one another in pursuit of our shared goal to move our organization and the communities we care for to become truly inclusive environments in which to live, learn, and work. And so we actually had a Juneteenth discussion and presentation in my division where we gave the history of Juneteenth, knowing a lot of people didn't know it. But then how does that impact on how we interact with our patients today in the light of everything that was going on? How does that influence our clinical investigations? Why might it be challenging for us to get a diverse group of people in our research programs? So we had several discussions within our group. And one of the main things that we decided is that we felt challenged, that we wanted to champion justice. So we knew that there were inequalities within our patient population, within our research participants. Was equality the answer? Well, we knew that didn't quite satisfy it, that there would still be some having equal access wasn't only the answer. Being equitable, maybe making up for some of the disparities, that sounds good, but does that fully answer it? And we decided no, that we wanted to be justice. We wanted to kind of straighten things and level the playing field for everyone, and then let them openly go for it. And so my division as a whole said, well, we want to do things that we think will help with justice for our patients. So we started to think, well, what could that be? And we decided to climb on to the social justice that Penn Medicine was doing. So Penn Medicine has had an appeal, I'm showing you the flyer, of trying to help our patients vote and to vote safely, hopefully by mail, or at least know that it's an option. We thought in geriatrics, if anybody needs to be promoting this, we did with our patients. But what we noticed is the flyer that Penn Medicine was doing was just this part at the bottom. And so basically the QR code and how to text. And as I mentioned to you before, and we had recognized already, some of our patients don't have smartphones. So this really wouldn't have been justice for them. It didn't level the playing field. So what we did is we added a telephone number that goes to a voicemail box, and one of my faculty checks it periodically every couple of days. And then individuals who call, we call them, one of us calls them back to help them with the process of how they can request a ballot by mail to make sure that they're registered. We've had over 50 or so patients call, which is not, the majority of our patients overall, but for us, we think that's a significant number that maybe otherwise would not have been able to access and be able to use their rights safely. So from a health vantage point, given that we take care of older adults, we want them to still have their civil liberties, but do so safely. So this is a campaign we're currently still in. So looking at moving forward, this has been a look back at where we've been so far in 2020, and certainly the year is not over. There's a lot of the year left, but I think that geriatrics as a specialty, and I've just given you examples from my division, but not to say that it's anything unique to us. I think these are just examples of opportunities and means that geriatrics as a specialty has had. We have a choice now. Do we go back to the way that we were interacting with patients and caregivers and individuals in the community before, where it's strictly focused about our research or our clinical care or educating, or do we go this other path where we have a broader perspective, a broader appeal of how we look at what healthcare means and total healthcare? And I think that we have this decision point that we need to make. I'm getting some signs that maybe we aren't going to go back to the way things have been before. And so the American Geriatric Society, for one, has updated its vision statement. And it now says, amongst other things, that they are committed to a future where we are all supported by and able to contribute to communities where ageism, ableism, classism, homophobia, racism, sexism, xenophobia, and other forms of bias and discrimination no longer impact healthcare access, quality, and outcomes for older adults and their caregivers. But the American Geriatric Society wants to do more than just kind of changing a statement or putting a position out. They're really looking to change kind of how they do things. So they have a diversity, equity, and inclusion statement. And this is what they're working on to move towards, just not having a statement, but to actually implementing it. And so they want to affirm a commitment to diversity, equity, inclusion. And they're going to do this by addressing DEI throughout their programs and products. So look for more programs and products that are focusing on equity, inclusion, and diversity. But I think the biggest sea change is likely going to be that they are strongly considering requiring diversity in research to be part of research plans. And so they're thinking that they'll roll this out over 10 years. But if this gets implemented, which it probably will in some form and fashion, I think on a national level, this changes how the field of geriatrics, or at least geriatric investigation and education and policy by AGS is delivered. So this will be coming out. They're just doing the last couple of rounds of meeting with people, but within the next month or so, you can look for how things are going to pivot from the AGS's point of view. More locally for us, going back to how it's impacted us, for now, our medical students, our preclinical students remain almost 100% remote, but our clinical students are on site. The preclinical come on site for physical diagnosis or things like that, but otherwise are pretty much remote. Our residents have returned to their normal functioning. The fellows are doing both virtual and in-person rotations for research. We have been able to move to, I think, level 2, so that now we can have 50% of our research teams back on site. So you can't have your whole team on site at a time. You had to come up with a schedule, who was going to be there when. But we went from 0 to 25 to 50%. So we might get back to 75% or 100% soon. And then particularly for our junior investigators, but for everyone, you've been able to apply, everyone's eligible to apply for a 1-year extension on the promotion clock, realizing that there's just been so much disruption to research and to try to alleviate a little bit of the stress that has caused, particularly people were getting near the time for their clock or had limited time. So it's been eligible for everyone to apply to have it extended. And then I mentioned with education, just some of the positives that came out of it. As I mentioned, the students went virtual, and so Allison and Emily and Mariana were 2 of our fellows, and Rachel came up with a virtual curriculum for our medical students that was pretty well received. It got very high marks, and they recently just had that published in JAGS in terms of the innovation. So as I say, necessity is the mother of innovation, and we capitalized on that. And then there's also GeriaFloat, so which is Geriatric Fellows Learning Online and Together. Our fellows were part of that. This is an article that was also recently published in JAGS, where it shows the different distribution of the first 5 sessions of where the fellows came from that participated in GeriaFloat. So it was an opportunity for our fellows to be part of a community, recognizing they're part of a larger geriatric community, not just at their own institution. And there's also a way to expand education so that if we couldn't do a lecture or didactic at our own institution, somebody else could do it, and our fellows' education wasn't jeopardized then. But you know, things aren't over yet, and looking at our COVID-19 cases in our area and the various counties around us, you can see that the peak isn't as high as it had before, but unfortunately our curve is kind of upticking, and so we're not out of the woods yet. And what does that mean, and how are we going to continue to pivot and change? One of the big things has been the Regional Response Health Collaboration Program. So in Pennsylvania, this is using the CARES grant funds, and our state decided that they would work with academic medical centers to help prepare the nursing homes if there's another wave of COVID. And so this has really been an exciting opportunity. It was kind of short time frame, but it's coming together really nicely. And so far, they've been able to accomplish a lot. They've done urgent testing and going out and doing COVID-19 testing at 43 facilities throughout the state. They're doing routine testing, a lot of site visits and consultation, which is part of the requirement. They're supposed to do 2 site visits or consultations before December 1st at each of the nursing homes, convalescent homes, assisted livings in the state. They've done some rapid responses, showing you PPE, doing fit testing. I think one of the most important things is working with local health departments and having a better collaboration between the state and the city health departments, which there's not as much collaboration there as one would expect. And then also, how do we work with the academic medical centers? But one of the things I think that's truly, truly exciting for us is that this has been an opportunity for geriatricians all over our state to work together on a project. And even though this is supposed to be time limited, we're laying the groundwork now that we can continue to collaborate and work together on issues for older adults throughout our state. In addition, this is a research platform the information that we're gathering. So we have investigators who are collaborating as well and be able to put into the literature the investigations that will demonstrate what we've been able to show in terms of the innovations that we've done. So I think that this again is kind of that pivot for us where we can go from just being at our own institution or trying to deal with geriatrics at our own place, but really having more of a regional, a statewide, a national kind of impact. And so before COVID started, I do mostly a consultation, and I had a patient who came to see me for a consult. And as I usually do, I asked why he was there. Excuse me. And he said, sorry. He said he had gone to one of my lectures, and so he wanted to come see me. And so when I mentioned to him, well, was there a particular issue or something he wanted to talk about? He said no. He said he wanted to see me because geriatricians are specialists in whole person care. And at the time I felt, wow, he really gets it. He knows what we do. Little did I know that the next few months was really going to show how we can provide whole person care. And it's not just the care we deliver face-to-face or virtually, but it's thinking about all aspects that are impacting our patients, their health and well-being. And I think that we are uniquely positioned as a specialty, as a field, to continue in this path of really delivering whole person care and being recognized as leaders in this area. So in my opinion, I think our future is pretty bright. I think that we, once we get through COVID, because I know we're not completely through there, but I think we're laying good groundwork and building blocks that we can build upon in clinical care and research, in education, public policy. I feel people know who we are in a way that they didn't know before. And so we really have this opportunity to continue to build on that and to remain at the table, so to speak, and to lead how things are done and how care and research and education is done and provided for older adults. So with that, I will end to leave, some time for questions. I thank you for your attendance. I thank everyone for meeting with me earlier today as well. It was really quite lovely to meet with so many of you and talk about synergies. I look forward to having continued conversations, and I'll open it up to any questions at this point. Thank you.
Thank you so much. That was tremendous. Are you able to hear me okay? All right.
I can, yes. Thank you.
So I have a couple questions and lots of kudos because so many people were commenting about all the great ideas. And so here's a couple of the questions.
I'll stop sharing my screen, so in case people want to, okay.
Perfect.
Go ahead.
So if older adults will be, and in many places already are, the majority of hospitalized patients, are ACE units and sort of age-friendly health system programs enough? Or is it still not enough, like what we do for children, where we have children's hospitals or, more adult hospitals, and then we're kind of just making adjustments to try and have it more age-friendly? Just to get your thoughts on the approach there.
Yeah. So is it enough? Obviously not, right? Like our ACE unit has 32 beds, and certainly there are many more than 32 older adults that could benefit and need our care. My understanding really is that, or I've always presented the ACE unit to health systems, that it's the living laboratory for how to provide the best care to older hospitalized adults. And it's never intended to just stay on an ACE unit, but to disseminate out throughout the hospital, so that in effect, you would have a geriatric or geri-sized hospital. But I think sometimes we've missed that opportunity and really kept what we've done in the best practices on our ACE unit when we really want to train others. And so I think that's why Ryan's idea of having hospitalists leading and us collaborating is such a fantastic one, because they rotate all throughout the hospital. So if you teach them the geriatric principles, they'll take it wherever they're going. If we have nurses who learn it and are champions, they can teach other nurses. So absolutely not. And the intention really should be to have the ACE unit be the place we kind of work out the kinks, but then disseminate it out throughout the hospital.
Terrific. And you're obviously doing a very good job of communicating, because there was one comment about how inspiring it is to see the ACE team be highlighted in a University of Pennsylvania video.
Oh,
And
good. Yeah, we felt the same way. We were all like, yay! So.
And do you have any thoughts on how that happened? Like, why did they choose to, why did the CEO like choose to focus on the ACE unit? Is it, do you think there was some messaging, or how did that, I don't know if you have any thoughts on that.
Yeah, I mean, I was, you know, beyond thrilled and that she decided to select our unit. I think that it's partly some relationship, you know, like I meet with the CEO of the hospital quarterly and let her know not only what we're doing, but what my strategic vision is for geriatrics on that campus. Before I came, I talked about making it a center of excellence in geriatrics care, and she really has bought into that. And so I think when she sees our outcomes, so for example, for us, last year for fiscal year 20, we called it the year of zero. So what ended in June, we had 0 CAUTIs, 0 CLAPSIs, 0 C. diff infections. So I think it makes it easier for us to make that pitch when you see that we're delivering high quality care in the way that you measure it, as well as the way patients and families think of it as being high quality care. So I would like to think it was a combination of those two, like ongoing and knowing what we're doing, realizing that this was the population that was being hardest hit, and yet still we are able to maintain really high quality standards and be able to, you know, have good outcomes for our patients.
Fantastic. There was also a comment of thanking you for sharing the beautiful and moving poem, and a lot of interest around this idea of championing social justice by helping older people vote, or older patients vote. Has anybody, are there other geriatrics divisions or other, I mean, how did that come to you? Or I'm just trying to think, is there any other examples of this? I think this is a great program.
Well, you know, so it's a Penn medicine program. So oh, I wish I had my ID. Like they have the little cards that have the QR code that we can hold on to our ID. So patients are like, what's that? You're like, oh, you can put out your smartphone. Yeah, do the code and register to vote. So they have fairs where they have pins, you know, vote and this and that. I'm a voter. There's a whole campaign with senior management. Why am I voting? You know, that kind of thing. And I don't know if it's being part of a battleground state. Like I've never lived in a battleground state before, but we saw it not just we want people to vote, but realizing we're doing all this work, right, to keep our patients safe. And we don't want them to lose out. And again, particularly in a place where there's a large minority community, people really seriously take, I mean, people died, right, to have the right to vote. This is a generation that lived through that themselves. And we know that they will go out regardless of the risk, meaning older adults, particularly older minority adults, to vote. And we thought that for us, it's really kind of, this is social justice and health imperative, right? We're doing all this work. We don't want to go backwards then and have a whole bunch of people sick come end of November, December. But like I said, it wasn't really applicable for our patients because it was intended for people who have a smartphone, and we know our patients don't. So we spent several weeks trying to think of how we could make this relevant to our patients and have it something that was welcoming and not making them afraid. And the telephone line was the way that we came up with that. So we've gotten really good feedback, not only the people that have called for help, but we've gotten some people who just called to applaud us for doing it. We got one person who said that we were being political, which is, you know, I guess you could view it that way. But I think out of, you know, 50, 60 some odd people to have one, there's always gonna be one, right? And so I don't know if other places are doing it. It'd be interesting. I would think that it makes sense for us to be able to do it. We're not telling you who to vote for. We're just saying vote.
Helping them get to vote. Fantastic. Well, I think that's a good place to end. So thank you so much. That was a tremendous and inspirational talk. So thank you so much for spending time. I know it's late on your side of the country, but thank you so much.
No, thank you.
Okay.
Have a good day, everyone.
Take care.
Take care. Bye-bye.